So today our webinar is PGTai 2.0 plus, reducing avoidable miscarriage by detecting all haploid and triploid embryos. And this webinar today really discusses some of the issues around miscarriage and some of the questions that are both embryology related, clinical related, and genomics related. And we hope that you'll enjoy this. The format is that we will have a presentation which really sets up this area from Dr. Christine McWilliams, who is our medical director. Then after that, we will be going to discuss this subject area with our two invited guests, Dr. Ahmed Omar and Dr. Alison Campbell, both from Care Fertility. And we will also be joined by one of my colleagues, Dr. David Grimes. So if we have any technical questions, he will be able to answer them as well. The webinar is recorded, so we can share it with you in the future, and these webinars generally go on to YouTube. Also, we're really trying to make this as interactive as possible. So if you have a question, we have a Q&A box on your Zoom. Your questions can be anonymous if you want to or not. And what we'll try and do is, as we go through, please put your questions up and we'll try and answer them towards the end if we have time, after we've had our discussions with our invited guests. So it is my pleasure today to welcome a number of different experts in the field to this webinar. The first one is Dr. Christine McWilliams. Christine is the Medical Director for Genomics at Cooper Surgical Fertility Solutions. She also runs our very busy genetic counseling program, where she guides the team's clinical decision-making and all the super interesting and never dull questions that come up with clinical genetics. Christine's worked in the field of pre-implantation genetic testing since 2013 and has a particular expertise, and I would say also interest, in PGTM. Christine obtained her MD and PhD from the University of Pennsylvania School of Medical Scientists Genetic Training Program. And her doctorate is in the field of human genetics and epigenetics. Also, I would like to welcome Dr. Alison Campbell from Care Fertility. She's the Group Director for Embryology at Care Fertility. She's responsible for 13 IVF clinics in the UK and Ireland, performing around 10,000 fresh and frozen treatment cycles with 100 scientists. She's a consultant embryologist and a fellow of the Royal College of Pathologists, a author, co-author of 50 publications and over 100 abstracts. She's the developer, implementer, and author of time-lapse algorithms to predict live birth. She is an executive board member of Alpha, Scientists in Reproductive Medicine, section editor of RRMBO, associate editor of Human Reproduction. And she established a dedicated training facility for IVF professionals in Manchester in 2018. And if you see Alison's picture when it comes up, her back screen is the facility in Manchester, which looks fantastic. She is the member of several scientific advisory boards and has interests in fertilization, embryo development and selection, and optimization of IVF lab processes and training and development of reproductive sciences. So welcome, Alison. We really look forward to hearing from you later. Also, I would like to welcome Dr. Ahmed Omar. Ahmed is the Medical Director at Beacon Care Fertility in Dublin. He has got some great in-depth knowledge of the fields that we're going to discuss, and his aim is to deliver the highest quality and most advanced fertility treatments for patients. Also, sometimes it's interesting to get a perspective from outside the UK and see the perspective of some of these tests from Ireland. His main area of specialty is pre-implantation genetic testing for aneuploidy and monogenic disease and SRs, recombinant implantation, and reproductive immunology. He is a graduate from Ain Sams University in Cairo and took further training in Europe. He's a member of the Royal College of Obs and Gynae since 1998, a member of the Royal Society of Medicine for Ireland, and a member of the British Fertility Society. He's carried out training in IVF at ARGC in London, was the Deputy Medical Director of SIMS IVF, where he established a number of processes and programs before moving to Care Beacon. So welcome, Omar, and we really look forward to hearing from you as well. The last person on here is my colleague, Dr. David Grimes, who's the Director of Business Development at Cooper Surgical, specifically Cooper Genomics. David I've known for many years. He is a PhD molecular biologist with a degree from the University of Aberystwyth, has worked in molecular diagnostics for many years, and has worked in the PGT field for over 10 years with a number of companies such as Blue Gnome and Illumina, joining Cooper Genomics in 2016. So welcome to you all, and I'm really interested to hear what we're going to hear from Christine, and hopefully it will generate a lot of questions. So for the people who've logged on, please, if you haven't, fill in the poll. Also, if you have any questions, please put them in the chat, and we'll try to come to those after Christine and during Ahmed and Alison's talks. So without further ado, I'd like to hand it over to Christine and her presentation. Thank you, Christine.
Thank you very much, Tony. Hopefully everybody can hear me. It's my pleasure to be with you today in support of this webinar and to give you a short presentation on miscarriage, an overlooked outcome. As way of disclosure, I am a paid employee of Cooper Surgical. And today we will cover a number of topics related to miscarriage. And the goals of the presentation that I'll give you today are to review the prevalence of miscarriage, highlight recent publications regarding impact of miscarriage, discuss genetic causes of miscarriage, and describe some technologic mechanisms for detection of aneuploidy that we have available, and demonstrate some evidence that these are able to reduce miscarriage. Firstly, miscarriage is common. In fact, it's estimated that 250,000 miscarriages occur in the United Kingdom each year. This represents 30 to 40% of all conceptions and 10 to 15% of clinically recognized pregnancies. Miscarriage tends to occur early on in pregnancy, with 80% of miscarriages occurring during the first trimester. Up to 22%, in fact, occur before clinical detection of pregnancy, and often occur so early that we're unable to obtain products of conception for additional testing to better understand the etiology of the miscarriage that has occurred. As we know, the risk of miscarriage increases with maternal age. For all forms of miscarriage, subclinical and clinical, for younger women, less than 35 years of age, about 20 to 25% of pregnancies will end in miscarriage. However, for older women, those greater than 40, that will be the result of 40 to 45% of pregnancies. For clinical miscarriages, ones that have pregnancies that have been clinically recognized, only 8 to 12% of pregnancies in younger women will result in miscarriage, but still a very high number will result in miscarriage for older women. The graph on the right shows not only that drastic increase in miscarriage as women age, but also the decrease of chance of live birth similarly as women age. Many women will experience more than one miscarriage in a lifetime. And in fact, prior miscarriage does increase the risk for future miscarriage. After one miscarriage, it's about a 20% increase that there will be a second miscarriage, but after 3 or more, that increase goes up to 43%, quite dramatic. And approximately 5% of couples will actually experience recurrent pregnancy loss, defined by ASRM as 2 or more failed clinical pregnancies. The graph on the right is from the ASRM committee opinion on evaluation and treatment of recurrent pregnancy loss, and shows that as the number of miscarriages increase, women are both less likely to achieve a live birth, and that achievement of live birth, if successful, takes longer on average. So it's quite a significant problem. Miscarriage is common, and miscarriage commonly has complications, both physical and psychologic. On the physical side, some complications include, but are not limited to, certainly, incomplete miscarriage, infection, heavy bleeding, and Asherman syndrome, which is scarring of the uterus that can follow dilatation and curettage for medical management of incomplete miscarriage. On the psychologic spectrum, both depression and anxiety are quite common following a miscarriage event. To get a little bit deeper into the psychologic morbidity of miscarriage, there's been some excellent work that has been done, actually coming out of the UK on this topic. And it has been found that depression and anxiety are very common in women following miscarriage. In fact, within 1 to 3 months of miscarriage, up to 36% of patients showed signs of clinical depression, and 41% of patients showed signs of clinical anxiety. Furthermore, 25 to 39% of patients can show signs of acute stress disorder or even progress to post-traumatic stress disorder. Fortunately, rates of depression and anxiety do decline over time, but did not return to baseline levels for a full year following the miscarriage event. This is further work from that same group out of the UK, and they've studied not just patients, but their partners, and have found that depression, anxiety, and post-traumatic stress are elevated, not just in the women who experience the miscarriage event, but their partners as well. For all of these, anxiety and post-traumatic stress sequelae do predominate over depression, and women certainly that experience a miscarriage event are certainly more affected than their partners, but still there's marked increase in both. Interestingly, for women who experience the miscarriage, the depression, anxiety, post-traumatic stress are higher immediately following the event, and do decline over time, though remain significantly elevated at 9 months. Whereas for partners, in fact, there's a peak in all of these events at around 3 months, which the authors for this study felt could be due to the couple considering a second pregnancy, trying again after the miscarriage. So what causes miscarriage? Well, aneuploidy is a very frequent cause of miscarriage. And in fact, it's estimated that 50% of miscarriages are caused by chromosomal abnormalities. For blighted ovums, aneuploidy is the cause of 90% of these. Embryonic miscarriages, aneuploidy is the cause 50% of the time, and 30% of fetal miscarriages are caused by aneuploidy. There are a number of commonly observed aneuploidies within products of conception, and the numbers here represent karyotype analysis of these products of conception. Numerical chromosome errors are the most common at 86%. And just to highlight a couple of, not perhaps so commonly thought of, but commonly observed errors within products of conception. 45X Turner syndrome observed 10% of the time, And triploidy and tetraploidy are also quite common at 6.5% and 1.8% respectively. Structural chromosome errors and even chromosome mosaicism are frequently observed within products of conception. This study here looked at, again, products of conception, but from using array CGH in addition with karyotype to look a little bit more deeply at the abnormalities observed. Autosomal trisomies are by far the most frequently observed aneuploidies within products of conception at 66%. Trisomy 16 is the most commonly observed. However, trisomy 22, 21, 15, 18, 13, and 14 are also quite common, with most of these being represented by the so-called acrocentric chromosomes. Autosomal monosomy, in contrast, is rarely seen in clinical miscarriage, with monosomy 21 being the most commonly observed when it is detected. And again, 45X, triploidy, tetraploidy, and structural errors are commonly observed as well. So what tools do we have to perhaps predict when a miscarriage or when aneuploidy is present and possibly avoid miscarriage? Well, in the IVF space, I think we're familiar with pre-implantation genetic testing for aneuploidy, or PGTai. And the intent of this test is to detect aneuploid events within embryos to help stratify which embryos would be most likely to go on to achieve a healthy pregnancy, where euploid embryos would be prioritized and aneuploid embryos deprioritized. And then, of course, mosaic embryos, which have some reduced potential, can be considered in some instances for transfer as well. There have been a couple of randomized control trials that have shown some impact for PGTai in reduction of miscarriage. However, it's important to note that for trials to date, study of miscarriage and miscarriage reduction was not the primary endpoint of these trials. The primary endpoint rather was achievement of increase in live birth, and that endpoint was not achieved. There's been two trials that, however, have looked at miscarriage as a secondary endpoint. One being ESTEEM, which was published in 2018. This utilized polar body biopsy and array CGH with single embryo transfer, and found that in the PGTai arm, miscarriage events were decreased by half relative to the no PGTai arm, and this was statistically significant. Similarly, the STAR trial, which was published in 2019, which utilized trophectoderm biopsy and next generation sequencing with single embryo transfer, did also find that in some age groups, there was a significant reduction in miscarriage in the PGTai arm relative to the arm that did not receive PGTai analysis. Studies such as these have been recognized to some extent by the HFEA, who released a statement that noticed that some of these RCTs have shown some evidence of miscarriage reduction with PGTai, however, highlighted that because PGTai in miscarriage reduction utilizing that technology was not the primary endpoint of the study, that the findings of miscarriage reduction should be taken into context. Which brings up a discussion point. Should a future RCT with miscarriage rates and miscarriage reduction via PGTai be considered as with a primary endpoint in mind? In addition to RCTs, there's been a number of studies that have looked at the impact of PGTai from a retrospective basis, oftentimes utilizing databases such as the SART database from the CDC in the US. I'd like to highlight today one very recent study that did this, looking at SART data from 2014 to 2016, and looked at both clinical outcomes as well as cost benefits with PGTai testing. Not mentioned here, but the authors did find that from looking retrospectively, for patients that did receive PGTai, there was improvement in live birth rates. However, these patients overall had also had a better clinical outcome. But focusing more specifically on the question of miscarriage, this retrospective analysis found that either considered on a per cycle or a per transfer basis, there was a statistically significant decrease in miscarriage events for patients receiving PGTai. And below, I think we've seen this really from a number of studies, but I wanted to highlight also that there was PGTai also afforded a reduction both in twin live births as well as higher order live births, and these findings were again significant. On the cost analysis side of things from this study, this top section shows some of the estimated average costs that the authors utilized in their cost benefit analyses for both for miscarriage, for singleton live births, twin live births, and higher order live births. And you can see the staggering increase in costs associated with either a twin live birth or higher order relative to singleton live birth. When they looked at the benefit of patients paying out of pocket for their own PGTai testing, though these patients did experience improved clinical outcomes, they found that for younger patients, PGTai did not provide a benefit. However, for older patients, there was both a cost benefit as well as improved clinical outcomes. And interestingly, on the payer side, either when insurance companies pay or government programs pay for IVF, PGTai would have provided a cost savings benefit for them across all age ranges. And this was driven very much by the additional costs of twin and higher order live births. And I think also shows, at least in the United States, how much fertility funding is actually flowing to NICU units rather than to IVF clinics and to fertility treatment. The purpose of this slide is to look a little bit closer at observed aneuploidies within PGTai, and also to compare against what is commonly seen with products of conception. This study here utilized array CGH for PGTai, and then karyotype analysis for products of conception. And what you can see is, again, that trisomies are very commonly observed in PGTai in the pre-implantation embryo, just as they are in products of conception. However, differently within pre-implantation embryos, monosomies are very frequently observed, whereas they are quite rare in products of conception. And this is most likely representative of the very early pregnancy loss that occurs following transfer implantation of monosomic embryos. Now, with the products of conception, again, polyploidies were seen at about 10% of overall samples, with triploidy and tetraploidy being observed fairly similarly. And although for both triploidy and tetraploidy, the male forms were more commonly observed, female polyploidy, either female triploidy or female tetraploidy, are actually quite common. Now, you'll notice that the PGTA arm here, or results, did not observe any polyploidy. That is not because polyploidy was not present in these pre-implantation embryos studied, but because the technology at the time was unable to resolve, particularly the female polyploidy from that of the profile of a euploid sample. Which further brings up the question of, as PGTA technology continues to improve and we become able to detect events such as female polyploidy, do PGTA outcomes improve? And in fact, there is at least one single center study that shows that they do. The data here that's presented here comes from an NYU presentation and research that they performed, where they looked at outcomes following PGTA testing via older forms of next generation sequencing versus the Cooper Genomics PGTai 2.0 platform. As a reminder, the PGTai 2.0 platform, which also includes a plus testing option, analyzes not just the copy number variants, or CNVs, that are common in older forms of PGTA NGS, but also SNP, single nucleotide polymorphisms, which together help both better resolve mosaicism events, but importantly, also finally be able to distinguish female polyploid embryos from their euploid counterparts. And NYU, in their analysis, found that, again, not shown here, but there was some improvement in live birth rates, but focusing specifically on miscarriage, there was a significant reduction in miscarriage utilizing the newer form of PGTai versus older versions of NGS, which raises, I feel, another discussion point that we may consider today, which is, if we do move to utilize PGTA specifically for the purpose of miscarriage reduction, or at least setting expectations for transfer with regards to likelihood of miscarriage, is it important to utilize a PGTA platform that detects female polyploidy? In summary, we've discussed today that miscarriage is a very common early pregnancy outcome. It has significant and very common psychological and physical complications. It's frequently caused by aneuploidy, and PGTA, which detects aneuploidy in pre-implantation embryos, has been shown by several studies to reduce miscarriage across age ranges. In fact, miscarriage reduction appears to be a driver for improvements in live birth rates observed following PGTA in those studies that did observe that outcome. And with that, I thank you very much for your time today. And Tony, I will send it back over to you.
Thanks very much, Christine. Great presentation and a great setup to this area. So one thing I would like to say is that we are open to questions. So if you have a question, something that maybe Christine has brought up in her presentation, or that comes through as we go through the questions here to our panelists, please put it into the chat and we'll try to get through it in the time allowed. So first of all, I'd like to welcome Alison. Great to see you, Alison. And we have a number of questions that have come through. So care fertility has been really at the forefront of a lot of the pre-implantation genetic testing technology. You know, it's over 10 years since the first 24 chromosome baby was born using CARES technology. And do you think that patients have a good understanding of aneuploidy, particularly with advanced maternal age, and how that impacts in the greater miscarriage rates that they see with advanced maternal age?
Well, yeah, I think patients are generally very well informed, and perhaps more so than ever before. However, if they do experience miscarriage, we know that it can come as a huge shock and cause a great deal of distress. So my impression is that women of advanced maternal age are generally aware that they do have an increased risk of miscarriage. And certainly that's my experience from speaking to our patients.
Yeah, it's I think something that, as the data's come through, that we're really able to give them more precise information, which I think is important. And as you say, it can still be a shock. And one of the poll questions that we asked, I'll tell you the answer before I ask you your opinion, so you've already got the information, was how many patients drop off after they've had a miscarriage. And we had a poll from 0 to 20, 20, 40, 40, 60 onwards. And it was really interesting that in the poll, let me just get it here on my image. So on the poll, which was pretty fascinating, because it was really strong. How often does miscarriage cause patient drop off? And actually 20 to 40% was over 3/4 of people said that was the incidence rate. And is that what you see in clinically?
Well, I don't know that we've got a figure on that, but what I would say is that whilst there might be a drop off, we're also seeing a different cohort of patients who've experience recurrent miscarriage from spontaneous natural conception. So we do see a lot of patients who have experienced miscarriage in the past, either through IVF or not.
Yeah, interesting. And you get a lot of patients that come from other clinics, because of the miscarriage and the sort of different things that care can offer?
I think if you don't mind, I
Sure.
Tony here. Yeah, I think we do. Yeah, because obviously we offer PGTai, especially I'm talking about Ireland. We offer PGTai, so we tend to see maybe more of the recurrent miscarriers that maybe have miscarried during treatment in other clinics, or actually have natural, as was Alison saying, natural miscarriages, and they wanted to really find out what are the causes of these natural miscarriages. So we tend to see more a little bit than other clinics, maybe because of offering the PGTai. But I do agree that, yes, there is a drop-off, and you see that because I think the emotional and also the physical toll of a miscarriage is bigger than just a negative IVF cycle. And realistically, a lot of these patients have a lot of fear regarding to coming back, especially if they have a miscarriage of maybe history repeating itself. So we see that that the duration between a treatment and the other is bigger, but also some of them, unfortunately, if they have 1 or 2 miscarriages, they might be maybe after this experience might not want to go through a similar experience. So yes, I do agree that there will be a drop-off in some of these patients.
Yeah, and you can see from that really interesting Tommy study that Christine presented, the psychological impact of miscarriage, how it delays the whole sort of process, absolutely for certain. Yeah. Alison, so one of the other poll questions was triploidy is only present in 1% of embryos, 1 to 2%. That's our own internal data from Cooper Genomics, but estimated to cause, and it's depending on the technology used, somewhere between 10 and 15% of chromosomally abnormal miscarriages are triploid. And Care, you've been doing quite a lot of technical developments that really can help that, such as time lapse. And how does time lapse help in that situation?
Well, if we accept that the fertilization process is dynamic and pronuclear appearance and fading, it's a transient thing. We've used time lapse to help us identify as precisely as possible the number of pronuclei to confirm a normal fertilization. What we have found, though, interestingly, is that just over 1% of the time, when we've seen 2 pronuclei with our time-lapse imaging, they change over time and become 3 or 1. So not very often that we see a change, but the fact that we do is really interesting. And importantly, with standard methods, we have to try and time our fertilization check to make sure we maximize the chance of getting an accurate assessment, conscious that they appear and fade at different times. So we have guidelines to work towards, consensus expert opinion. We should check 17 hours plus or minus 1, and that's post-insemination. But we've done a huge study, a time-lapse study of over 27,000 zygotes. And we now believe that we need to shift back from that time window, because we can catch 98.5% of them if we score them around 16 hours. So we need to go in a little bit earlier, at least with standard assessment. So we're learning all the time, and it's so important. You know, one more embryo can make all the difference. We don't want to be missing any signs of fertilization.
Yeah, that's fascinating that we get to this point, you know, after decades of IVF, and we're still not actually looking at absolutely the correct, precise time. I didn't know that. It's fascinating data. You know, I think it just shows you can't take anything for granted in embryology at times, can you? And ICSI clearly helps the timing for PN checking, because you've got a set fertilization time. And one of the main causes of triploidy is two sperm, diandric triploidy. Is that a consideration for using ICSI, or is it really ICSI still predominantly used just for male factor indications?
Well, yeah, in our hands, it's predominantly for male factor. I know some clinics in the US will use ICSI for 100% of the cases. We hover around 50%, and it generally is male factor. However, if a patient's had IVF treatment in the past with a high incidence of triploid fertilization, diandry, then we would suggest moving to ICSI.
Yeah, understood. And CARE have some interesting steps that you've developed, particularly for recurrent miscarriage. I'm not sure whether it's Alison or Omar or both of you would like to comment on the CARE Unity test, which is it's really one of the very few tests that are available to try and help with miscarriage.
Yeah, shall I?
Yeah, Alison, if you want to
I'll introduce it and hand it over.
Yeah.
Well, CARE Unity is a screening test which helps identify and then go on to treat patients who are at risk of miscarriage and other placental problems. And basically, carriership of this C4M2 haplotype results in a significant reduction in annexin-5, which is necessary, as far as I can tell, for placental integrity. So if either the egg or the sperm provider is a carrier of this variant, then the person carrying the pregnancy can be treated with low molecular weight heparin to reduce the chance of miscarriage. So do you want to say any more, Omar? Did I get that?
No, and then I think the impact of it as well is in the early pregnancy. I mean, the rate of miscarriage is higher in couples that one of them is carrying this genetic variation, but also I think the risks, because it affects placentation, the risk of later problem in pregnancy or abnormal placentation like preeclampsia, intrauterine growth restrictions, all these are other issues. So it might have some implication as well on the pregnancy later on, not only in the early part, which is the miscarriage part.
Yeah,
and our experience, sorry, just to say, it's more common than we might imagine it, and our data suggests that that it's about 44% incidence in our fertility clinic patient population, compared with about 15% in the general population.
And I'm right in saying as well that if it doesn't have to be maternal, if it's a paternal haplotype, that has almost as much impact as the maternal haplotype.
Correct. Yeah, it's conveyed embryonally. Yeah.
Yeah, which is fascinating. Yeah, absolutely fascinating. So other things that you might look at, and one of the things that you mentioned was the use of embryogen, blastogen, which are the granulate GM-CSF, I'm not going to even say it. Thank you. Yeah. A particular media that helps in embryo development and potentially reduction in miscarriage. Do you use that for particular patients? Which patients would you use that for?
Yeah, we would recommend that to patients who have had recurrent implantation failure or recurrent miscarriage. I don't think we fully understand the mechanisms by which it works, but yes, it's a cytokine enhanced culture medium. It's recombinant, and we believe that it enhances the communication between the embryo and the endometrium, but certainly in our hands, we've not done a huge number of treatments, but we're really satisfied with the results so far.
Yeah, that's great to hear. And one last question just to you, Alison, then we move on to Ahmed and then come back to Christine as well. So one of the hot topics of the day in the embryology and genetics crossover is mosaicism. And I don't know whether you saw, there was a fantastic paper out recently, which was the transfer of 1,000 known mosaic embryos. That was a Viotti paper, and they had a really interesting, it was a kind of dose response. With the more mosaicism you had, the worse the outcomes were. And it's really interesting because mosaicism is turning into quite an emotive subject, that a lot of people will say that you can transfer a mosaic and it has very little impact, but it appears to have, you know, quite a substantial impact in miscarriage. You know, if you have a lot of mosaicism, then your chances of miscarriage start to head towards what an aneuploid pregnancy would be. And do you think patients have, and how do you message that to patients if you have only a mosaic embryo to transfer?
Well, it's difficult, but I'd say at Care Fertility anyway, we have a multidisciplinary team, and together we devise and review our practice. We try and keep abreast of the literature, and our policy, we have a policy which relates to prioritization of embryos for transfer following PGTai, and we can transfer low-level mosaic embryos with you know, patients being fully informed, counselling offered. It's a difficult one, but yeah, I think that's what it's all about: clear documentation and advice for patients, so that it's accessible, and accepting that different patients have different perspectives. Some of them want to proceed with such a transfer and others do not. So it's a difficult one for the clinics to manage, but I think just transparency and keeping up to date with the literature, like this paper in Fertility and Sterility, which was fascinating. I think it's important.
Yeah, I think
sorry, I do agree with Alison in the sense that yes, the most important thing is the counseling of the patient regarding to the risks, and as long as they are well informed regarding to the risk of miscarriage. Remember, some of these patients as well, maybe their kind of natural risk of miscarriage might be higher than the risk that we are offering them with a mosaic embryo. So it still might be an improvement in transferring, let's say, an untested embryo regarding the risk of miscarriage. So, and also the acceptance of the patient to these risks. But I think it's key making sure that they're properly counseled about it.
So actually, we've had a question come through as you were speaking. It's always interesting when you're in these to see what it is. And it's from an anonymous poster. And it says, why do your panelists think that the Royal College of Obs and Gynae, ESHRE and other bodies do not agree with the Unity test? I mean, I think that the Unity test has some pretty good data, but you haven't done a randomized controlled trial with it. But I'm not sure how you could do a randomized controlled trial with it. Have you considered that?
We'd always love to get engaged with randomized controlled trials, but it's really difficult for us. It's very difficult. It takes a long time, a lot of investment of time and financials involved to get these tests done. So I think the best we can do, at least with this example, is it will cause no harm, I believe. We are fully transparent with patients. We've built this test on our own experience, our own data, and we're still learning and we're still developing the data set. So I think it's all about transparency. It's a new test, so we've got to start somewhere, but we are confident in it.
Yeah, and I think the data is pretty robust for observational studies, but some people will only take randomized controlled trials, as we know, as the only measure of success. Yeah. Alison, I'm just going to come over to Ahmed for a little while. Ahmed, so thanks for joining us today. We're really looking forward to hear from you. So, recurrent miscarriage, as we've heard, is a serious psychological barrier to continued treatment and family planning. How, if people have had recurrent miscarriage, do you bring that into the conversation? And how do you talk about PGTai in the context of recurrent miscarriage?
Obviously, some of them, and I have to admit that some of the patients that have recurrent miscarriage are quite well read. They've done their own research before even coming to the clinic, and maybe have learned a little bit about possible causes of miscarriage. And so that sometimes make life a little bit easy. But I think I divide it into two groups, really. The first one is the embryo itself. What are possibly the causes that could be increase the risk of miscarriage from an embryo point of view? And obviously one of them is the risk of aneuploidy. Okay, and I think this is one of the main causes, really, in my view, regarding to miscarriages. So I also explained to them that this is not necessarily the only risk, okay, or only cause. But there's other causes, but this is one of the main causes, and obviously it depends. The advice does not only depend on the number of miscarriages per se, but the age of the patient. So you have to correct that to her own natural risk of miscarriage at that age, in addition to maybe the additional risk of the number of miscarriages that she had. And probably that make it even more valid, when you are talking to them about maybe the next step like PGTai.
Indeed. And do you think that people have realistic expectations of what PGTai can do? Because, when you look at the data that Christine presented from ESTEEM, from STAR, from SART and their retrospective analysis, there's clearly reduction in miscarriage after PGTai, but you don't eliminate it. There's obviously either genetic factors that we're not finding or factors other than genetics that are involved there. And do you think we're being realistic in how we describe how much impact PGTai can have for these patients?
I think it's up to the clinician, really, so patients, sometimes they don't know what to expect. And realistically, it's our job to make sure to explain to the patient, because they're obviously, if they had a number of miscarriages, they're quite desperate in finding a solution to that. And realistically, you have to be realistic and clear in explaining that although it can help to reduce the risk of miscarriage, it does not eliminate it. So miscarriages can still happen with a chromosomally normal embryo. And this is so the counseling part, again, is a very important part of giving this patient a realistic expectation of the outcome of their treatment. And I think once they are well counseled, their ability to deal with the treatment after that becomes much better.
Yeah, I think, one of the things that's come up from what Alison said and what you said is clearly counseling is very important. And I know CARE have been at the forefront of bringing genetic counseling to genetics and IVF, and it's great to see their commitment to that sort of space. So, certain other things that we should consider when we're looking at miscarriage, are patients carriers of balanced translocations? Would you normally recommend that? And then if they are balanced translocation carriers, what would be the next steps there, as opposed to an idiopathic miscarriage? Recurrent miscarriage.
Obviously, if they have a number of miscarriages, if they have recurrent miscarriages, this is one of the primary investigations that we ask them to do, is karyotyping for both partners to rule out a balanced translocation. That would be the first step before really going down the route of PGTai, let's say. And obviously, if they do have a translocation, if one of them carry a translocation, then the next step for us, it's a genetic pathway. So the first part of that genetic pathway is to send them for genetic counseling, okay, to be able to counsel them regarding the type of translocation itself. Does it carry a risk how much is that risk regarding to recurrent miscarriages, and also some of these translocations, the effect of having a baby with an abnormality due to translocation. And based on that, once they are counseled, and we know that looking for this translocation is the real cause for their miscarriages as well. Okay, because just from my experience, some of the translocation may be less important than others regarding to the mechanism of miscarriages. Once they are counseled regarding to that, and we then go down the route of the genetic pathway of getting in touch with the geneticist regarding whether we can look for that type of translocation in the embryos. That's again is another important step. And then after that is the pathway of having the IVF treatment, producing the embryo, biopsying the embryo, and finding the results for them.
Indeed.
So, and I think once they have that proper kind of genetic pathway, it means that the chances of them being successful at the end of it is much better.
Absolutely. I have one question I'm going to put to David and Christine, and then I'm going to come back to some general questions. So we have a question from the audience, and please, if you have any questions, please put them down in the chat box, and we have a few minutes, we might get back to them. So it's a question from the audience, and it says, have you validated your platforms for triploidy? For instance, have you any publications that have followed up POCs from PGTai to validate the platform? David, Christine?
Hi. So yes, we have. Is the short answer. So for triploid and haploid, we have done an extensive amount of validation looking at both PGTai and PGTM samples across multiple platforms, and are able to categorically, I shouldn't use the word categorically, we are very confident in our ability to detect these forms of abnormalities, particularly if we have the parental samples as a secondary confirmation. So these have really been carried out for many years in use of technology based on SNPs, global SNPs, looking at inheritance patterns. So yes, I would say the answer to that is a strong yes. I don't know if Christine would like to add something.
Absolutely. I think the only thing I would add is just your point that we've been detecting polyploid samples for some years, but via our PGTM platform rather than PGTai. And that really does highlight the power, the importance and power of bringing the SNP analysis to PGTai, because what we had detected for years for PGTM is now available for PGTai.
Thanks, Christine, David. So coming back to Alison and Ahmed and Christine, our apologies, this is a sort of slightly UK specific question, Ahmed, but you might still want to comment. And in the UK, as we all know, we have the infamous traffic light system for recommendations of add-ons, and there was a recent update to the traffic light systems, and they nuanced the language a little bit to say that there was no primary evidence from randomized control trials for the reduction of miscarriage, which means that that wasn't the first stated aim of randomized control trials. Secondary aim was always in the PGTai randomized control trials, reduction of miscarriage incidence. How important do you think it is that it has to be the primary aim to show in the SCAC committee world that it is there? Are you happy with the evidence that we have at the moment that the PGTai is reducing miscarriage?
Well, firstly, I'm glad that we don't have the traffic light system here in Ireland, so that's quite useful for us. But no, I think I'm happy with the data that have been already shown without the randomized control trial. However, saying that, I think probably a randomized control trial with maybe be a bit more proof of these data, and as well there is, just to maybe give a little bit more confidence for people maybe who are a little bit skeptic about these findings in being able to get some reassurance. But again, from a clinical practice, we said we deal with a lot of couples that have recurrent miscarriages that have gone through PGTai, and a lot of them had successful outcomes. And I think I'm kind of pretty confident that if that happened in the future, there will be evidence to support the already present finding.
Alison, Christine, did you have anything else to add there? No? Okay. So Christine introduced her presentation, a lot of the issues we see with miscarriage, and exactly how negatively it impacts and how important it is. So I shall give you the answer to the first poll question we had and see what your thoughts are. So what do you consider the benefits of PGTai, if any? And it was a multiple choice and you could answer more than one area. Implantation, it's important to get patients pregnant. Reduction in miscarriage, it's so traumatic that reducing miscarriage is extremely important. Live birth rate per treatment cycle, baby take-home rate is the most important benefit. PGTai has not been shown to have any benefits for any of the above. We don't offer PGTai. And we had 2% of recipients, 8% of recipients didn't offer PGTai. Nobody thought that any of the benefits above were benefits of PGTai. And interestingly, 80% of people thought that miscarriage was extremely important, and 42% thought that baby take-home rate was the most important thing. Are you surprised with those results? What are your thoughts? Stunned silence.
Not unexpected though. Yeah.
But I mean, do people come in to see you, and are they already, you know, is the avoidance of miscarriage already very high on their priority list, or is it, you know, reduction? Is it reduction in miscarriage or baby take home?
I think a lot. Yeah, go ahead. Sorry, Alison, go ahead. Sorry.
I would say, I would think from my perspective anyway, the patient's priority is take home baby, and the strongest motivation is that, and it's not avoidance of miscarriage. But Ahmed, you see patients every day of the week, so you'll probably know much better about patients' perceptions.
Yes, this is I think it's the primary aim of any couple going through fertility treatment is to have a baby rather than to have even a pregnancy, you know, and this is where the focus is generally on, you know, but also, you know, the experience of patients going through miscarriage is a very hard experience, you know, and it's off-putting, and until you are able to maybe help them to try to reduce this risk of miscarriage, they believe if having a live birth is not there. So I think it's an important still step in that final goal that they're having of having a baby. But there's no doubt that this is why they come into a fertility clinic. I mean, the patients that we deal are healthy. Okay, the only reason why they're going to a clinic or a hospital for treatment is because they want a baby. So, so that's the primary goal. But obviously, we can't just brush aside the psychological impact of having miscarriages itself, and sometimes that might be the overriding fear for patients going through even attempting to have a baby.
Yeah, it's interesting because this poll to our attendees is to a poll of healthcare professionals rather than patients. And I wonder whether, because you have to deal with the downsides of miscarriage, that has skewed it from what patients would be to what healthcare professionals would be.
I think so.
From the patient perspective, it's quite interesting. You know, Tony, as you mentioned, I head up the genetic counseling team for Cooper Surgical. And we obviously interact with patients who have been referred for or who have chosen for PGTai. And we get an interesting perspective on what they hope PGTai will do for them. And it's interesting, patients who, even patients who are planning on transferring mosaics and considering even transferring high-level mosaics, they still find PGTA of use for them, because even if if the result is miscarriage, it helps to put into context for them and understand why it may have happened. Whereas I think otherwise, so many miscarriages occur so early before we're really able to get answers as to why. Many patients are left wondering, was it me? Is it my body? Was it the embryo? What was it? And at least PGTA is able to give them some information there, or they feel that it is. So I think it could be interesting. You know, we talked a little bit about the studies that have been done so far and looking at the psychologic impact of miscarriage. I think it'd be interesting to look at that in the PGTA patient population, to see, if patients have PGTA, or if they don't, are they better able to cope with the event?
I sense a GC project coming up there, Christine, as we've been discussing GC projects. So I did warn Alison and Ahmed that an hour would slip by in the blink of an eye, and we'd have questions and it would go through very quickly. And that is what has happened today. And it's been a great conversation. I think we could talk for much longer. Really interesting subject. I would just like to thank both David and Christine, my colleagues, and Alison and Ahmed, our external experts,